Welcome to the Deep Dive. Today we are diving deep into a set of revision notes covering a really important topic. Human Papillomavirus, or HPV. We have this stack of detailed notes here touching on everything from what this virus is, how you get it, and crucially, how we manage it and what it can lead to.
Yeah, quite comprehensive.
Exactly. And our mission, to sift through it all and pull out the absolute highest yield information for you.
You know, the stuff you really need to know.
Think of this as your shortcut to getting thoroughly informed, maybe even helping you prep for an exam or just understand this common virus better.
Precisely. It's incredibly common, but the details of why it matters, which subtypes are key, and how prevention really works can sometimes get lost in the noise.
Yeah.
What's fascinating here, I think, is how a single group of viruses can have such a broad impact, from, minor warts to really serious cancers.
So let's unpack these notes together and identify those essential nuggets you need to know.
Let's do it.
Okay, let's kick off right at the beginning, according to these notes. What exactly is human papillomavirus?
So the notes describe HPV as a group of viruses, and it's primarily transmitted sexually. It's actually a really large family, classified into over 100 different subtypes.
Wow, over 100.
Yeah. They broadly categorize them into mucosal and genital types, non-genital ones that affect the skin, cutaneous, and then a specific, quite rare type linked to a condition called epidermodysplasia verruciformis, or EV.
Okay.
Biologically speaking, it's a non-enveloped virus with a circular double-stranded DNA genome. It typically gets into the body through tiny breaks like microabrasions in the skin or mucous membranes.
Right.
And it infects the basal stem cells there.
Okay, over 100 subtypes is, well, it sounds overwhelming. But the notes make it very clear right away that you don't need to know all 100 plus zones, do you? They really focus our attention.
Absolutely not, thankfully.
No.
This is probably the most high-yield point to grasp early on for revision. The notes clearly differentiate subtypes based on their risk level for causing serious disease, particularly cancer. We have the low-risk types, notably subtypes 6 and 11. These are the ones primarily associated with causing low-grade precancerous lesions and, very commonly, genital warts.
Okay, 6 and 11, low risk, warts. Got it.
Exactly. And then we have the high-risk types.
Which are the ones everyone worries about.
Exactly. The notes highlight subtypes 16 and 18 as the main high-risk culprits. These are the ones strongly associated with high-grade intraepithelial lesions. Those are significant precancerous changes and ultimately malignancies, meaning cancers.
So 16 and 18.
Yes. If you remember anything about HPV types, remember this pairing. 6 and 11 for low-risk warts, 16 and 18 for high-risk cancer. It's a fundamental distinction, really key for exams.
That's a great memory tip. Okay, so the type of HPV matters hugely in terms of what it can lead to. But the notes also mention that just having a high-risk type isn't always enough to cause cancer. It seems other factors are involved.
It's a critical point, yeah. The notes indicate that for cancer to actually develop from a persistent HPV infection, you often need cofactors or triggers, things that sort of help it along.
Like what?
Well, they list things like smoking, being immunosuppressed, like in HIV or perhaps transplant patients.
Right.
Nutritional deficiencies such as folate deficiency, UV light exposure, which is more relevant for skin cancers linked to certain HPV types, and even pregnancy is listed as a potential cofactor.
Interesting. So it's not just the virus. It's the virus plus these other things that could tip the scales towards serious disease.
Exactly. It really emphasizes that context matters. It's not automatic.
That makes perfect sense.
Yeah.
Shifting gears slightly, how does someone actually acquire this virus? What's the etiology or cause of infection, according to the notes?
The notes are very clear. The primary mode of transmission is through sexual contact.
Oh.
This includes vaginal, anal, and oral sex. Because the virus infects skin and mucous membranes, any direct skin-to-skin or mucous membrane contact during sexual activity can potentially transmit it.
So quite easily spread then.
It is, yes. And as we touched on, once acquired, it can lead to those various conditions like warts or precancerous changes, depending on the type and other factors.
And based on that transmission route, who would the note say is most at risk?
Well, the notes list several clear risk factors. Having unprotected sex increases risk, which is understandable. Multiple sexual partners also increases the likelihood of exposure. Early age of first sexual activity is listed too, possibly related to the biological maturity of the cervical epithelium at younger ages. A weakened immune system, as we mentioned, is a significant risk factor because the body has a harder time clearing the infection.
Right, it can't fight it off as well.
Precisely. And then there are broader categories, like specific behaviors or lifestyles that might increase exposure or perhaps impair immune function.
Yeah.
If you think about these factors, it's largely about maximizing the opportunity for exposure and minimizing the body's ability to effectively clear the virus once exposed.
Right. That makes sense. Let's get a bit more technical, as the notes do. Once the virus is in the body, what's the process? How does it actually cause these cellular changes? What's the pathophysiology?
Okay, yeah, this section of the notes is really key to understanding how high-risk HPV leads to cancer. So the virus infects those basal stem cells in the epithelium, the skin, or mucous membranes.
Okay.
What's really fascinating is how it interacts with the host cell. High-risk HPV types, like our friends 16 and 18, have this ability to integrate their DNA into the host cell's DNA.
Ah, right. So it actually becomes part of our own cell's instructions.
Kind of, yes. Think of it like inserting a rogue instruction manual into the cell's existing operating system. And this rogue manual disrupts the cell's normal control mechanisms, particularly the genes that regulate the cell cycle, the ones telling cells when to grow and when to stop.
Okay, so it hijacks the controls.
Essentially, yes.
Yeah.
By integrating, the virus forces the cell to keep replicating in an uncontrolled way. It often produces more viral particles as it does so, but critically, it also makes the cell ignore the body's signals to stop growing or to self-destruct if it becomes damaged, a process called apoptosis.
Right.
This uncontrolled growth, which is driven by specific viral genes, often called E6 and E7, though not explicitly detailed in these notes, they're the usual suspects. That's the fundamental step towards those precancerous changes, dysplasia, and eventually cancer.
And the low-risk ones don't do that.
Generally, no. Low-risk types like 6 and 11 usually don't integrate as readily. They tend to stay separate within the cell's nucleus, causing cell growth like warts, but typically not progressing to cancer in the same way.
That exploration of integration versus staying separate, that really clarifies the difference in risk. Thanks.
No problem. It's a core concept.
So, given that HPV can cause different things or might need to be distinguished from other conditions, what do the notes list under differential diagnoses? What else might be considered?
Well, the notes list the conditions that HPV itself can cause, framed here perhaps as the specific diagnoses you might arrive at or consider when someone presents with certain symptoms.
Ah, I see. So the outcomes themselves.
Exactly. They list genital warts, cervical dysplasia, there's abnormal cell changes, cervical cancer, and anal cancer. These are the clinical presentations or outcomes that would lead you to suspect or diagnose an HPV-related issue. It sort of reinforces that these aren't random diseases. They are potential manifestations of persistent HPV infection.
Okay, got it. Let's talk numbers. How common is this virus? The notes mention the UK specifically. What's the epidemiology like?
Right. The notes highlight that HPV is incredibly prevalent in the UK. A very high proportion of sexually active individuals will acquire an HPV infection at some point in their lives. Most people, in fact.
Wow, really? Most people?
Yes, it's that common. The good news is, as we'll discuss, most people clear it naturally without even knowing they had it.
Okay.
However, cervical cancer is specifically mentioned as the most common HPV-related cancer in the UK, which really demonstrates the significant public health impact of those persistent high-risk infections that don't clear.
So, it's widespread, but often goes unnoticed. How would someone actually know they have it then? What are the clinical features described in the notes?
You've hit on a crucial point the notes emphasize. Infection is very often asymptomatic, completely silent. Many people will have HPV and never ever know it.
All right.
When it does cause visible signs, the most common are genital warts. These are visible growths. They can vary a lot in size and shape, sometimes single, sometimes multiple.
Right.
For women particularly, the notes highlight that abnormal cervical cell changes might be detected during routine screening tests, even if there are absolutely no outward symptoms. So it can be silent or present as visible warts, or just show up on a screening test.
That brings us neatly to diagnosis. If it's often silent, how do we find it? What are the investigations mentioned in the notes?
Good question. The notes detail a few key ways we investigate for HPV or the conditions it causes. For visible warts, often a simple visual inspection by a clinician is enough for diagnosis. But for those silent cervical changes, screening is absolutely fundamental. The notes highlight the cervical screening program, particularly for women aged 25-64 in the UK.
And what does that involve?
It involves two main tests, often used together now. First, there's the Pap smear, or cytology, which looks under a microscope for abnormal cell changes on the cervix that could be caused by HPV.
Right, the cells themselves.
Yes. And second, and increasingly central to screening protocols, is the HPV DNA test. This test actually detects the presence of the virus itself, specifically looking for the DNA of those high-risk types, like 16 and 18.
Ah, okay, so you could look for the virus directly now.
Exactly. And the notes really emphasize that the power of screening lies in detecting these changes early, often at a precancerous stage, that dysplasia we mentioned.
Before it becomes cancer.
Precisely. Allowing for treatment to prevent cancer from developing altogether, or catching any cancer that has developed at a very early, much more treatable stage. Oh, and a biopsy of any abnormal tissue found during inspection or screening is also listed as a way to confirm the diagnosis and, importantly, grade the severity of the changes.
Okay, so we know what it is, the risks, how it works, how it presents, and how we find it. What do the notes say is the approach to managing HPV and its related conditions, particularly in the UK?
Right, management. According to the notes, there's a really strong emphasis on prevention, first and foremost. This is probably the most impactful strategy overall.
Makes sense. Stop it before it starts.
Exactly. Vaccination is a cornerstone. The notes mention it targets subtypes 6, 11, 16, and 18, the four main ones we've talked about. This vaccine is offered routinely to boys and girls aged 12 to 13 in the UK, aiming to prevent initial infection with the most problematic types before they're likely to be exposed.
Okay, vaccination is key. What else?
Regular cervical screening, as we just discussed, is also a critical preventative measure because it catches problems early, stopping cancer from developing.
So screening is prevention too, in a way.
Absolutely. It's often called secondary prevention. And then there's general advice, including safe sexual practices like consistent condom use. Condoms can reduce, though maybe not completely eliminate, the risk of transmission.
Okay. What about if someone already has an infection or related issues? How is that managed?
Yeah, the notes cover managing those situations too. For individuals who are immunocompromised, managing their underlying condition effectively, like with appropriate antiretroviral medication for HIV, is really key to helping their body control the virus better.
Right, boosting their own defenses.
Exactly. And patient education is vital for everyone. Reinforcing the importance of safe sex, explaining the rationale behind pap smear or HPV screening, and discussing risks associated with things like multiple partners.
If the screening finds something, those dysplastic changes.
If abnormal cell changes are detected, the notes outline a clear pathway. Often, the next step is a referral for colposcopy.
Right, you mentioned that. Can you explain what colposcopy is again in this context?
Sure. Colposcopy, as mentioned in the notes, is a procedure where a clinician uses a special magnifying instrument. It's called a colposcope, basically a mounted binocular microscope, to get a really detailed, illuminated view of the cervix.
Okay.
They can apply special washes, like dilute acetic acid, which temporarily turn abnormal areas white, making them easier to see. And then they can take targeted biopsies from any suspicious-looking areas.
And if those biopsies show significant changes, like high-grade dysplasia,
then the notes discuss treatment options for that high-grade dysplasia or for persistent high-grade changes. These treatments aim to remove the abnormal tissue. Options mentioned include cryotherapy, which freezes the affected tissue, LEAP, which stands for loop electrosurgical excision procedure.
LEAP?
Yeah, that uses a thin heated wire loop to precisely cut away the abnormal tissue, or a cold knife cone excision, which is a more traditional surgical procedure using a scalpel to remove a cone-shaped piece of tissue from the cervix.
So different ways to remove the problem cells.
Exactly. The choice often depends on the size, location, and severity of the changes, and patient factors too. The goal of all these is to remove those precancerous cells before they have a chance to become invasive cancer.
And what if, unfortunately, it has progressed to cancer?
In that case, the notes state that for established HPV-associated carcinoma, treatment becomes more intensive. It would typically involve things like surgical excision of the tumor, which might mean a hysterectomy or more localized surgery depending on the stage, potentially combined with chemotherapy and/or radiotherapy. The specific plan depends heavily on the type and stage of the cancer.
So the management strategy really spans that whole spectrum, doesn't it? From preventing infection entirely to detecting and treating early changes, right through to treating invasive cancer if needed?
It does. It's a multi-layered approach.
Okay, that's a comprehensive view of how it's tackled. What about the future outlook? What's the prognosis like, according to the notes?
Well, the notes state that the prognosis really varies. It depends heavily on what specific condition the HPV has caused.
Right, back to warts versus cancer.
Exactly. And it also ties back to that high-risk versus low-risk distinction, and crucially, whether the body clears the infection. Most HPV infections, especially those low-risk types causing warts or even asymptomatic high-risk infections, are cleared by the body's immune system on their own within, say, 1 or 2 years. In those cases, the prognosis is excellent.
That's reassuring.
It is. However, it's the persistent infections, specifically with those high-risk types like 16 and 18, that carry the risk of progressing through dysplasia to actual cancer over time.
And the prognosis then?
Well, the prognosis for these more serious outcomes depends hugely on how early they are detected and treated. Early detection through screening dramatically improves the prognosis for conditions like cervical cancer. Catching it early makes a massive difference.
Screening is just so important then.
Absolutely vital.
And finally, what are the potential complications listed in the notes? What can go wrong?
Well, the complications listed are essentially the diseases we've been discussing all along, the potential outcomes of the infection, particularly persistent infection with the high-risk types.
Ah, okay. So the complications are the diseases themselves.
Pretty much, yes. These include genital warts, though often considered more of a nuisance than a dangerous complication that can be distressing. Then cervical dysplasia, cervical cancer, anal cancer, and other less common but still significant HPV-related cancers like those of the vulva, vagina, penis, and also some head and neck cancers, particularly oropharyngeal cancers.
Wow.
So it's important for you to view these as the potential complications of the initial viral infection. They show the serious potential downstream effects if high-risk infections persist and aren't managed.
Okay, so looking back at this wealth of information from the notes, all these details, what stands out to you as the absolute core takeaway? What's the really highest yield insight for someone revising this?
That's a good question. For me, what's most striking, beyond the specific facts, is the public health triumph embedded in this topic. You have this incredibly common, often completely silent virus that, in a minority of cases, and usually influenced by those cofactors we talked about, can cause devastating cancers years or decades later. But our understanding of it, the virology, the link to cancer, the specific high-risk types, has led directly to highly effective population-level interventions.
You mean the vaccine and screening?
Exactly. The vaccination programs designed to prevent infection with the most dangerous types before exposure, and the screening programs designed to catch precancerous changes early enough to treat them effectively. The journey from understanding the basic science of the virus to implementing these widespread preventative strategies is, I think, the most powerful story here.
Yeah, I can see that.
It highlights how scientific knowledge, when applied well through public health policy, directly translates into saving lives and preventing suffering on a huge scale. It's fundamentally changed the landscape of diseases like cervical cancer in countries with good programs.
That was a truly impactful deep dive into human papillomavirus, pulling the core knowledge straight from these revision notes. It's amazing to see the whole picture laid out from the basic biology to those major public health strategies.
Yeah, connecting the dots is key.
We hope this deep dive has been a valuable resource for you, whether you're hitting the books for revision, maybe for the MSRA, or just wanting to cut through the information overload and understand this important health topic better.
And remember those key distinctions we hammered home: 6 and 11 low risk, mainly warts, 16 and 18 high risk, linked to cancer, and grasp the twin pillars of prevention: vaccination, ideally before exposure, and consistent screening for early detection. Knowledge is most valuable when understood and applied, and with HPV, applying that knowledge through those preventative measures is absolutely paramount.
Absolutely. And if you are indeed preparing for the MSRA or just want more structured materials to support your learning journey, you can find resources tailored specifically for that at passthumbsra.com.
And for a wide range of excellent free resources to help you with your studies across various topics, be sure to explore freemsra.com.
Thanks for joining us for this deep dive. Keep digging, keep learning.